this last section we'll be looking at inflammations and different pathogens and malignancies of the heart. So starting with pericarditis, so the pericardial layer is the sac that protects the heart. Remember that we have the fibrous pericardium, and then we have the two serous layers of the pericardium, the parietal layer and the visceral layer. The visceral pericardium is sometimes just known as the epicardium, and that's where the coronary arteries will spring from. So you can see a little bit of the inflammation there. The itis, of course, means inflammation. And here you can see room in the pericardial sac where we hold fluid. So if fluid builds up slowly in the pericardial sac, often from pericarditis, this is a benign effusion, and somehow the pericardial sac can accommodate, can adjust, and this is not good, but it's not the worst thing in the world. This can progress to cardiac tamponade if fluid builds up too quickly in the pericardial sac in a way that the pericardium can't sort of dilate and adjust over time. High yield in a vignette. It's going to be worse with inspiration. It's relieved by sitting up and leaning forward, and patients will have a friction rub. I think previously in a previous section I said friction rub, you can hear an auscultation of the lungs. I looked it up a little bit more. Sometimes you can hear it in the lungs, but apparently the best place is between the apex and the sternum is where you'll hear the friction rub. It's this sort of grating sound like sandpaper rubbed on wood, and it's really just the heart friction as it moves against the inflamed pericardium. There is widespread ST elevation versus MI, which will be localized to the LAD or the LCX, the RCA, or the PDA, which usually in a right dominant 84% comes from the RCA. We also have PR depression, which is another way to distinguish this from an MI. Often it's idiopathic, but you know what? I'd say the biggest one is viral. So in a vignette, look for somebody who was sick last week, 2 weeks ago, has a runny nose, etc. Coxsackie virus B is a major cause. A couple days after an MI, you might have pericarditis, or kind of on the other side, several weeks or months later, you also get it, but it's a different pathophysiology a couple of weeks or months later. It's called Dressler syndrome. It's an autoimmune condition in this case that induces the pericarditis. And here, PR depression, ST segment elevation. And again, it is very important to know that it is widespread. It is diffuse. It is all the leads, not just a couple leads. Very fun. So cardiac tamponade often develops from pericarditis, and it's where blood compresses the heart. And it just can't fill properly. So here, if we get too much fluid in here too quickly, it'll press on the heart and it can prevent the filling. And it also screws with the contractions. It's just bad to have fluid filled in the sac compressing the heart. So pericarditis is a big cause. Cancer, again, we're looking for a lot of effusions really quickly. Type 1 aortic dissections, which sort of makes sense. Type 1 versus type 2. Type 1 is ascending. Type 2 is the descending abdominal version. And in the ascending, it might sort of trickle back downwards into the pericardial sac. Remember that the pericardial sac you can think of as the heart is like a fist going into a balloon. And so that's where we're going to have the visceral pericardium, the epicardium, which is the where your hand is in contact with. The space in between the balloons is the pericardial space where the fluid is, and then the outside of the balloon is the visceral pericardium in contact with the fibrous pericardium, not in the balloon analogy. And so, if you think about my fist in the balloon, my wrist and my forearm, those are kind of representative of the aorta. So the aorta needs a way, and you can kind of see it here, right? Here's my pericardium, but boom, this would be where the aorta, where my wrist and my forearm are leaving. So if I leak blood right on the type 1 aortic dissection, it might leak out and then it might come back down here and fill in this space over here. So type 1 specifically, rupture of the ventricular wall. This is 7 to 14 days after an MI. Remember, we also have the pseudoaneurysm, which is also basically a ventricular wall rupture, 7 to 14 days. Someone just stabs you in the heart, you know what? That can definitely cause cardiac tamponade. And post-surgery complication, you get heart surgery, and for whatever reason, you get a rupture a couple days or a week after or something like that. Signs of this, Beck's triad. So these first two definitely make sense. Hypotension, yeah, you're compressing your heart. It's not going to be contracting effectively for various reasons. Jugular venous distension, we have a hard time filling the right ventricle, and so it might build up into the superior vena cava, which builds up into the jugular, which is a major vein in your neck. And the distension is just the fact that it's swollen because of all of the extra blood that it's trying to accommodate. Those make sense. Those go together. This one also makes sense, but it's still a little bit different. You hear these muffled heart sound during auscultation, and that's because all of the fluid is going to affect how the sound is penetrating your tissues and getting to your ear. So the fluid muffles the sound, so it sounds a little bit distant. Pulsus paradoxus. Okay, this is a little bit complicated to explain, but during inspiration, the intrathoracic pressure decreases. This means that the right atrium and the right ventricle will, in addition to the fact that we have more oxygen in the pulmonary circuit, which causes a vasodilation, so lower pressure. So during inspiration, for two different reasons, we have lots of blood rushing to the right atrium, which means we rush into the right ventricle. This swelling of the right ventricle during inspiration is going to bulge against two things: the interventricular septum and also the pericardial sac. So imagine 50% bulges into the IV septum, 50% of the pericardial sac. Well, bulging to the IV septum means that it's going to then compress into the left ventricle. The left ventricle is going to get smaller because something's budging into it. And this is going to decrease your stroke volume, which decreases your systolic pressure. So normally, forget cardiac tamponade, just normally systolic pressure goes down a little bit during inspiration. Now this effect is exacerbated during cardiac tamponade. Why? Because the same pathophysiology. You inspire, which means more fluid in your right ventricle, which means it's swelling and it needs to accommodate, it needs to bulge in some direction. This pressure from the fluid in the pericardial space is just so not willing to budge. It's just so much pressure that it's not going to accommodate at all, which means earlier I said 50-50. Now it's going to budge way more than it previously did. 100% of the budging goes into the interventricular septum, which means however much smaller the left ventricle and the systolic pressure became in the previous example, it's just going to be exacerbated now. So specifically, we'll see a drop greater than 10 millimeters of mercury. We have a low voltage QRS amplitude. The pericardial fluid is hindering normal ventricular contraction, and so we're going to have the conduction of the signals. So this is just going to have a lower amplitude for that reason. Electrical alternans, not only is the amplitude, the actual height of it going to be lower, right? So we can see that this is maybe a little bit short, but also the heights are going to be different. That's because the heart's sort of swinging. I imagine it's like being suffocated by the fluid. It's sort of swinging back and forth. Like you should be able to tell that this is a normal heart, and this one is frantically swinging back and forth because we have all of this fluid which is compressing it. I imagine it like someone being strangled and then just fighting up and down, up and down, up and down, up and down. That's what's going on with the heart. So that is the electrical alternans. A little similar to the pulsus paradoxus is the Kussmaul sign. So during inspiration, we said that blood wants to flow into the right atrium and the right ventricle, and therefore into the pulmonary circuit because of the decrease in pressure. That still holds true. If you do an inspiration, all of those two same factors, the pulmonary vasodilation and the decrease in intrathoracic pressure, the swelling of the right atrium to the right ventricle and the mediastinum, all sucks in fluid or tries to suck in fluid from the venous system. But if cardiac tamponade or other conditions, constricted pericarditis, restrictive cardiomyopathies, right heart failure, pulmonary embolism, etc., lots of things can cause this. If we have a blockage, so blood is trying to be sucked in, but it just actually has a hard time getting into the right ventricle, the right atrium, it kind of rebounds. And where does it rebound? It rebounds up into the superior vena cava and into the jugular jugular vein. And during inspiration now, you actually see a little twitching. And that's just it getting filled with fluid as the fluid tries to go into the right atrium and sort of rebounds and goes up to the jugular. So the pressure might actually increase, but it might stay the same as well. It's just usually it decreases, and we don't see that here. So that's Kussmaul's sign. Myocarditis, inflammation of the myocardium. Myocardium is the thickest layer, right? Epicardium, endocardium, and then we have the myocardium, which is most of this. This is going to enlarge the heart. Usually this is viral in origin, Coxsackie-B is just a common virus we see affect with various heart conditions. It could also be different types of parasites or bacteria could cause it. Doxorubicin, the chemotherapy drug, does lots of things to the heart. Cocaine does lots of things to the heart, right? It can change the slope for diastolic depolarization of Purkinje fibers. It can cause vasospasms, which contribute to angina. Myocarditis can also be autoimmune in nature. And so apparently I read somewhere it's the leading cause of death for people under 40 years for sudden cardiac death, where within 1 hour of symptoms, usually like an arrhythmia that the myocarditis might trigger, causes death. This might be neck and neck with hypertrophic obstructive cardiomyopathies, which is for athletes, young athletes, is a common cause of arrhythmias and sudden cardiac death. People are going to present with chest pain and dyspnea. Endocarditis, three major types. There's really a fourth major type. So acute is going to be more severe, rapid onset, a couple of days. And this is going to be caused by staph. Subacute, less severe, slower onset, and viridins, streptococci. Liebman-Sachs, I think I have this one actually. This is SLE, systemic lupus erythematosus. So lupus is going to cause Liebman-Sachs. I believe it's Loeffler's, Loeffler, Loeffler's endocarditis, which is due to autoimmune allergies, anything causing eosinophils to aggregate in a tissue. Risk factors will be mitral valve prolapse, a bicuspid valve, which we know comes from Turner syndrome, prostatic or damaged valve, or any other congenital defect. Dental procedures, have a lot of bacteria in your mouth, and this bacteria during a dental procedure can enter into systemic circuit and go to your heart, where it can, cause endocarditis. IV drug use as well. We're going to get drugs into our heart. So specifically what happens is we might have damage in the endothelium from hypertension or a bad valve or something like this. And then we get a clot. So this is platelets and fibrin, which are going to form a clot. And then bacteria, shown here, go ahead and they grab onto the platelets with adhesins, and then they recruit more bacteria. They form a big old biofilm, so we get vegetation. We just get a colony of bacteria. That's why things like dental procedures or IV drug use is going to be a risk factor. And then the bad valves are just going to make it more likely that there's damage and there's a place to bind onto in the first place. So where are they specifically going to bind onto? Typically, when we're going through a valve, or, I've said it a million times, continuity equation, the velocity speeds up, which means the pressure decreases. So ironically, we actually have a low pressure in this areas where we have a high velocity. The pressure is especially going to be lower on this side if most of the stuff's going through there. So they're going to be here. This is going to be the lowest pressure area that they could find. And so as an example, if I was talking about aortic regurgitation, blood's going through right there. So we might see vegetation on either side of the valve there. And it just looks like this. We get these gross vegetations. So IV drug use, a lot of people go IV drug use right-handed side. And that's probably mostly true, especially for a vignette. But just know that IV drug use bacteria still usually causes left-sided endocarditis. Most endocarditis is on the mitral valve, maybe the aortic valve, over the tricuspid valve. But the difference is that someone's going to shoot up into a vein and it's going to go to the right side of the heart first. So most IV-related endocarditis will be left side of the heart. But if you do see a right-sided tricuspid endocarditis, boom, 100% it was from drugs. So keep that in mind for the vignettes. So from Jane, common symptoms of endocarditis: fever, Roth spots, oscillator nodes, murmurs, Janeway lesions, anemia, nail bed hemorrhage, and emboli, septic emboli from bacteria. So what happens is we have these bacteria, have all of this stuff going through, and we have these bacterial colonies, this biofilm forming, and then some of them might break off and then just go with the flow through our systemic circuit. And these emboli are actually responsible for causing all of or most of the other symptoms that we see. So the septic emboli can get caught under the nail beds, cause splinter hemorrhages. They can get into your palms and cause Janeway lesions. So importantly, these are small and painless. This is distinct from oscillator nodes. Oscillator nodes are a lot grosser to look at. They're raised and they're very painful. So I would just say that's a common thing. I know this is confusing for students, so this might commonly come up in questions. Note that this is just septic emboli on their own, but this is the emboli, which is as an antigen, some protein with an antibody complex. So it's a type 3 hypersensitivity. We also might get Roth spots, which is the type 3 hypersensitivity getting trapped in the eye. It could also go into the kidneys, contribute to glomerular nephritis. Rheumatic fever. So think about immigrants coming in from developing countries. This is going to be a sequela, 10 to 20 years after someone develops rheumatic fever from a streptococci infection. And this is a type 2 immune-mediated autoimmune disorder. So antibodies against the M protein of a streptococci are going to basically mistake innocent myosin as the antigen. So this is just classic molecular mimicry. The mitral valves and the aortic valves are the most common. Early lesions are going to lead to regurgitation, and later lesions are going to lead to stenosis. Ashkoff bodies is this large perimeter here. It's a granuloma just filled with giant cells. And Anichkau, I don't know how to pronounce it, cells or macrophages with wavy rod-like nuclei. You can kind of see here if you zoom in a little bit. So these enlarged macrophages, wavy rod-like nuclei. And we have the Jones criteria for any sort of rheumatic fever. So J, joints, someone's going to have polyarthritis. Heart, the O, stupid, is supposed to represent the heart. So this is obviously what we're concerned about. And notice that this is actually most of the symptoms. So most people who have rheumatic fever, the heart and the arthritis is going to be the main symptoms that we're concerned with. So it's entirely possible someone has rheumatic fever and they don't have the erythema marginatum. So you might have nodules in the skin, you might have erythema, you might have chorea, but for the most part, you can definitely account on the arthritis and the heart. So because this is a heart NBME, everything's going to be a heart. But if someone has arthritis, not a lot of other, if any, diseases that pathologies we've gone over that have included arthritis as a symptom. So this should be a big tell. Syphilis, another sort of ticking time bomb, right? So rheumatic fever, 10 to 20 years. This is 10 to 30 years after the infection. This would be tertiary end-stage syphilis. It's going to affect lots of different parts of the body, but for right now, we're focusing on the heart. The vasa vasorum. Remember that the arteries are so large and thick. There's so many layers that it's kind of like with the myocardium, right? The myocardium, it can't just get blood from the heart because blood's really bad at diffusing. It can only diffuse to like 1 or 2 cells, not hundreds or thousands of cells. So the blood vessels, the larger arteries, actually have their own blood supply, the vasa vasorum, and this gets disrupted by tertiary syphilis, which causes vessel atrophy because it's not getting enough oxygen. Just like if I had an infarction, like an end STEMI or maybe even a STEMI. So now that the vessel atrophies, and it's usually the aorta, this is going to cause dilation. And calcification is going to be a big one of the aortic root, which we've said can lead to aortic insufficiency, which really just means aortic regurgitation, and the aortic arch. You get this kind of tree bark appearance is how it might be described. All this calcification over here kind of looks like tree bark. And then cancers, myxoma is going to be the adult tumor often found in atria. This is sometimes said to have a ball valve appearance. And I'm not a cool enough manly man to know what a ball valve is exactly, but I Googled it. That's a ball valve, and that's our cancer. And they kind of look similar. I buy it. This is associated with syncope, IL-6 production, and you're going to hear what's described as a tumor plop sound. And if you think about it, it's in the atria, so this should be a diastolic murmur, right? Because the atria fills the ventricles during diastole, so diastolic. And then for kids, they're just going to have rhabdomyoma. This is associated with tuberous sclerosis, which we'll talk more about in the neuro unit, but not a lot to talk about right here. And here we got this big old thing in the left atrium. That is our myxoma.